taken care of by something at your home. Secondly, there is a high rate of infection associated with vaginal delivery. The vagina is similar to the mouth. It is something that has germs in it that can affect the baby and can get inside the uterus. And once your bag of water is broken, your risk of infection inside the uterus into the baby can be significant and can cause problems with the labor process and cause significant problems with both the mom and baby's health in a very fast time. And the sooner that you can catch that with monitoring the baby with electronic fetal monitoring and taking the temperature regularly, it's very important, and that's better done in a hospital setting. And the most common complication of things that we see on labor and delivery units is bleeding and hemorrhage. All vaginal births are associated with blood loss. The average blood loss from a vaginal delivery is approximately 400 to 500 cc's of blood. And for most of you, you're like, well, how much is that? It's about 1 to 1.5 Coke cans full of blood. And so for most people, this can be quite shocking in your home, and that's a normal delivery. Unfortunately, we also take care of a lot of women who have a hemorrhage, meaning that their uterus does not clamp down, or there's something bleeding very aggressively. And it's really important to be able to assess them with blood pressures and monitoring, and to be able to act on it quickly. And acting on it by coming in by ambulance and being assessed, it may be too long and contribute to prolonged bleeding. And so having access to intravenous fluids and to blood products if needed, and to having the right medications to stop the bleeding are all really important. And so if it were me and I was advising a patient, I would say that you would be better served delivering in a hospital. The other part of that question, and I think I really dealt not only with the effects to the mother, is the effects of the baby. All too often we have really beautiful heart rate tracings on babies, and they come out just a little bit not perky. The old adage about spanking your baby on the bottom to get it to breathe can certainly be exaggerated. Sometimes babies do come out floppy, or they come out not breathing on their own and need assistance. And it's really not fair to your loved one or your labor coach to be putting them in such a responsibility to help revive a baby and take care of you, whether you're bleeding or not, at the same time. And at hospitals like Memorial Hermann and other hospitals in town that have a neonatal ICU resuscitation team, there's a special team always on call to come help with your baby in the event that your baby doesn't come out looking perky, to help get your baby breathing and help minimize any potential brain damage that can be caused by hypoxia at birth. And I think everybody would want that for their baby. I hope that answers your question. I didn't address your question about water birth, and I think that's really up to your obstetrician. We do not recommend water birth in our practice, only because of the infection rate that we talked about, and that it is very difficult if you do have an epidural and things like that. So in my practice, I do recommend monitoring the baby during labor, which is difficult to do in water, and try to keep down the infection rate. Francisca writes, recently there was a study released saying that women don't need to gain very much weight at all while pregnant. What do you recommend for women to gain? What if they go over that? Okay, well, this is a really sensitive topic, since most women are very sensitive about their weight. We do, during your pregnancy care, weigh you at each visit, and there's a few reasons. Yes, there is an ideal amount of weight that you should gain in pregnancy. And for the average woman, and when I say average, I mean looking at your body mass index, which you can look up on the internet. If you're a normal weight and a normal body mass index between 21 and 25, then we recommend you gain approximately 25 to 30 pounds during your pregnancy. And if you happen to be someone who is overweight or obese going into your pregnancy, you want to try to gain less than that. Your baby will still be well nourished. Your baby will take from you the nutrients that it needs. And we aren't asking you to lose weight during your pregnancy, but we ask that you try to limit your weight to approximately a 15 to 20 pound weight gain if you're overweight to begin your pregnancy. For those of you on the lower end of the spectrum who have trouble gaining weight, or who have always been very thin, and you find yourself below a body mass index of 21, we ask that you gain approximately 30 to 40 pounds depending. And all of these measurements that I gave you pertain to having a single baby, not twins or triplets, and your situation would be completely different with multiples and guided by your doctor. Now, great question, Francisco. What am I going to do with you if you gain too much weight? And I don't think that your doctor is going to do anything to you. The real risk is that with increased weight gain, that you are increasing your risk of having a cesarean delivery. All of the studies show that women that are overweight to begin with or have a high weight gain during their pregnancy have a higher rate of cesarean delivery. Also, during your third trimester, increased weight gain can make your baby very large, and you can develop gestational diabetes. Gestational diabetes is diabetes of pregnancy. It is brought on usually by the placenta during the third trimester. We screen all women for gestational diabetes between the 26th and 28th week of pregnancy to ensure that you're not developing this condition. Gestational diabetes is associated with larger babies that can have difficulty navigating the birth canal, and babies that become hypoglycemic or have low blood sugar after pregnancy. So in a nutshell, gaining a lot of weight during your pregnancy can lead to some adverse outcomes like a C-section or having a baby that's born to gestational diabetic mother, things that we'd like to avoid. In addition, whenever you're in your postpartum period and you're showing off your new baby to the world, you don't want to have a lot of excess weight that you can't get off to keep your own health and cardiovascular condition healthy. The average woman loses approximately 15 pounds in the first few weeks after delivery. And so if you're putting on 25 to 30, it's less to lose than if you gain 40 to 50 that you know women have in the past. Marla asks a question about the delivery experience. How do I get it to make sure that the labor experience goes the way I want it to? And I really don't want a lot of hospital people coming in and out of my room. Well, this is a good question, and this is exactly why people ask about home births, is because they have this picture in their mind of what the delivery day is going to go like, and they feel or they've heard that at a hospital that doesn't always happen. I think this is a really good point, Marla, and you can help guide the hospital day by giving your labor and delivery nurse as well as your physician some of your ideas of how you would want your day to go. Patients often produce what's called a birth plan, and this is a set of instructions that they want for their labor day. I do find that when my patients have a birth plan and they are too stringent upon what they think that their day is going to go like, they try to plan it out like a wedding or some other day where they have every hour planned and every step planned in detail, that they're unhappy with the way things go because labor and delivery is not predictable. It's hard for a lot of patients to get used to that idea because their days are predictable during the day. They wake up, they go to work, they come home, they have dinner. As obstetricians, our day isn't like that, and neither is the labor process. It's very unpredictable. Some people have fast labor, some people have slow labors, and we have to all learn to be a little flexible. But in general, if you provide your caregivers, your nurse that's caring for you in labor and your physician with some guidelines of things that you want, whether you only want your husband or your partner in there with you, or whether you want your whole family to have a birthday party for your baby, or whether you want certain pain medications or not, or whether you'd like music in your room or not. It's a great idea to make a wish list of kind of things that you would like and then ask and discuss them with your doctor. I find that when patients ask me about their birth plan, that we can come to some understanding of why certain things on their list are great and why things really could be adapted to be a little bit more flexible. But in general, Marla, I think that your doctor can make it go your way. Sheila asks, how long does it take most women to get pregnant? And when should you be concerned about your ability to get pregnant? And what options are available if you can't get pregnant naturally? Sheila, infertility is a very big issue on many women's minds. For some women, they start to worry about this if they have reached a certain age in their life and they haven't started family planning yet, but they think, am I going to be able to get pregnant? And some women come to me with this question when they've been trying for many months or many years without success. So I'm not sure exactly where you're coming from, but I want to try to address your concerns. The average woman takes less than 1 year to become pregnant. Now, we all know those people who said that the moment they got off of their birth control method, they became pregnant. But there are a fair amount of people that it takes more than 6 months to get pregnant, and that's considered normal up until 1 year. I would become concerned about your ability to get pregnant doing the current method that you're doing if you aren't pregnant within 1 year. But me personally, I would see a doctor if I'd been trying for 6 months and hadn't conceived yet, to see if there's something that we can do slightly different to help speed up the process for you. In terms of options, sometimes, you know, when I talk to patients about fertility, the conversation it can be complex, and so I'll draw out a little drawing for you, and this is really basic. But I think this helps address the concerns. When you talk about fertility, you have to have two things that we all know. We have to have sperm, and we have to have eggs that come from your ovaries. This is a rough drawing of your uterus, your cervix, your uterus, your cervix, your fallopian tubes, and your ovaries. And this is a rough diagram of what a sperm looks like. So every month you have to have an ovulation and a sperm in order to get pregnant, okay? And you also have to have open or patent fallopian tubes so that whenever the egg is dropped, it can be sucked up into the fallopian tube where it meets the sperm that swim into the fallopian tube. This is actually where conception happens, is in the fallopian tube. So you have to have ovulation, sperm, an open fallopian tube, and then once the embryo or early baby is made, it drops down into the uterus and implants into the uterine cavity. So you have to have a healthy uterus, an open fallopian tube, an ovulation, and sperm that swim, and a good number of sperm. When you come into my office at 6 months and you haven't conceived with 6 months of trying, I start assessing, are we ovulating correctly? Is your uterus healthy and can accept a baby? Are your fallopian tubes open? And does your partner have a high enough sperm count and an effective number of sperm count? And we try to tailor treatment to one of those 4 conditions. Or sometimes people have 2 conditions going on at the same time that are causing their infertility. Great questions. Christy asks, if someone has diabetes, how can they ensure that they have a healthy pregnancy? Depending on the type of diabetes that you have, Christy, it might be important to take medications in your pregnancy or just to eat a healthy diet. Either way, the goal is to have an intimate and close relationship with your physician in planning your meals and planning your medication regimen and keeping a tight control of your glucose. For those of you who aren't diabetic, diabetes it can either be a condition you're born with or a condition that you get over time that makes your insulin not effective, or that you don't have enough insulin. Or insulin is like the key that unlocks the door to where our sugar can go into our cells. And so for people who are pregnant and have this condition, it's important to keep their blood sugar at a normal level. The baby is taking sugar away from you, but also your placenta is making it hard for your blood sugar to be controlled. So the short answer is that you should make sure you keep good glucose control. Tell your doctor when you're out of control, and make sure that the baby is being monitored by ultrasound during the 3rd trimester for growth, and that the baby's heart rate is assessed during the 3rd trimester. And you should probably be followed by a high-risk doctor. Sheila writes that she's heard a lot about gestational diabetes, and are some people at risk more than others? Are there things that we can do to help prevent gestational diabetes in pregnancies? Absolutely, Sheila. There's a lot of talk about gestational diabetes, even though it's not a very common condition. People who are at more risk are people who are overweight, an older age at time of delivery, meaning over 35, people who have a family history, a strong family history of diabetes, meaning one direct relative like a mother or father or a grandparent. And things that can help prevent this condition can be just eating healthy in pregnancy and maintaining your exercise routine during pregnancy. And I haven't touched much on that, but a lot of patients ask me, Doctor, can I continue to run, or can I continue to walk, or I'm a swimmer, I lift weights. And all of these things, all of these activities are safe in pregnancy. It's really important to keep your body in cardiovascular condition because you're going to have a lot of work to do lifting your own body and your extra weight during your pregnancy and during the labor process. So to prevent gestational diabetes, some of it you have control, some of it you don't, but try to maintain a healthy diet as well as get some regular exercise 3 to 5 times weekly. Stephanie is asking a question about vaginal birth after C-section, and the question is can a natural birth be safe after 3 cesarean deliveries? In all the medical literature that's out there, Stephanie, the only studies that I've seen are on vaginal birth after 2 C-sections or 1, and but after three C-sections, I would not recommend a vaginal birth. You guys have come up with some really great questions. I really appreciate your input, and it makes me understand what patients want to know and what need to know and sharpens my skills. We at Memorial Hermann are very happy to have helped you today and look forward to these web chats in the future. Thank you so much.